The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, and welcome to today's webinar presented by HSG. Today's webinar is Approaching Independent Physician Practices, How to Prioritize, Acquire, and Employ in the COVID-19 Era. Before we begin, a few housekeeping items. One, submit all questions via the Webinar Questions tab on your control panel, and we'll do our best to answer as many as possible at the end of the webinar. If you have questions but are not able to submit them, you're welcome to follow up with Neil or I at the end of this webinar. If you do submit a question during the webinar, we will not identify your name and or affiliation when submitting your question. Two, today's event will be available for on-demand viewing on our website, www.hsgadvisors.com, by this time tomorrow. Everyone who attends today's webinar will get a link to both the video and the slides as soon as they are posted. Okay, so jumping into today's presentation, my name is Travis Ansel, Managing Partner with HSG. With me is Neal Barker. We are, again, discussing how a topic that is coming up more and more frequently with our health system clients around the country, which is we're having a lot of independent practices approach us. We have concerns about the viability of some of our independent practices in our market. How do we prioritize those, recognizing that hospital finances aren't in the best shape at the moment? How do we prioritize? What criteria do we prioritize on? And then the second part of that is once we've prioritized independent physicians or practices that we feel we need to align with, what do we do? What are best practices for acquisition and employment? Which we find tremendous variability on around the country. So we wanted to have some discussion around best practice. As a reminder, HSG, we're a national healthcare consultancy focused really on helping organizations build competencies in employed physician network management and strategy. You can see our service array on the right. This is one of many webinars we're doing during the COVID-19, we'll say, era. We have other webinar offerings coming through late May and into early June, and they're available at the link at the top of this slide 4. They're also available at the end of the presentation. So in terms of today's content, first we'll be talking about our observations on what's going on with the independent physician market during COVID-19. We've had a chance to have a number of conversations around the country, kind of understanding both urban and rural markets. But what's going on with the independent practices right now. Two, some thoughts on how we recommend evaluating and prioritizing acquisition opportunities and what criteria we recommend when doing so. Then three, Neil's going to talk a little bit about our views on executing successful transactions, what that process looks like, what data goes into it, how to make sure once we've decided we want to go through with an acquisition, how that goes as smoothly as possible and as successful as possible once that practice is onboarded. And then we want to circle back around to talking about management priorities for 2021 in an environment where we expect most employed networks are going to grow. Some are going to grow significantly in the next 6 to 18 months. So how do management priorities change, and what do we need to reevaluate? So jumping in, starting with our observations on independent practice dynamics during COVID-19. On average, we talking to health systems around the country, for all the reasons that the current environment has been devastating to health system finances, it's been worse for independent practices. In a lot of markets, we're seeing, if everybody thinks back to whenever their particular explosion in employment was in their market, which we saw in most markets between 2008 and 2012, we're seeing the dynamic where that a little bit of that is going to return over the next 2 years, where those remaining independent groups that have been destabilized by the financial challenges of not having big cash reserves and having to manage through an environment where they couldn't quickly add tele and virtual health capabilities, and where they were prevented from doing elective and routine care for 2 months, and having to furlough employees and all of those associated challenges. That's going to result in a lot of currently independent practices seeking employment somewhere. Happen to see a podcast that involved Warner Thomas, the CEO of Ochsner Health, last week, who had many of the same comments. I felt liberated to steal one of his quotes from that podcast, which was, we're going to see a lot of consolidation in the industry in general, but especially in the physician area, and physician groups that are independent are just don't have the reserves to make it through this type of event, which we completely agree with. So thinking about what we're seeing around the country, across April and May, seen a lot of provider movement, both in independent practices within a market seeking employment from hospitals, as well as migration of providers across markets, which we're going to focus on a little bit less, but certainly a dynamic. A lot of our Florida clients, a lot of our clients in states that have been hit a little bit less hard in the COVID pandemic, seeing providers that maybe they haven't historically had access to in terms of recruitment, and that appears to be directly the result of providers who are in heavy urban markets that might struggle a little bit more with the pandemic over the next 6 to 18 months. Providers leaving that environment to seek environments where they can be more successful. So that's been interesting. We're really going to focus on independent practices within a market for the content of this webinar. What we're seeing, a lot of anecdotal examples of practices that have historically not been receptive to entrees about employment now being receptive to those. We see a lot of independent practices getting proactive in approaching hospitals and saying, this was probably the last straw in us staying independent. We really need financial support in order to remain in the community. And in some cases, especially in markets where large physician groups, single specialty or multi-specialty exist, we're seeing some splintering of those independent groups, in some cases prompted by health systems, in some cases happening on its own. And that appears to be the dynamic of different partners within an independent practice valuing the economic risk of the current and future environment differently. So with all of that movement going on and all of those attitudes shifting, we're still largely seeing our health system clients not really engaging providers in those discussions for the most part. There are certainly some exceptions, but that being largely related to, one, from a health systems perspective, we're just trying to get our reopening plan executed. So we really can't focus on acquisition activity right now. And two, we've just taken a 40 to 60 to 70% impact on our revenue over the past 8 to 10 weeks. Acquisition and spending additional capital and bringing additional providers into our employed group that we're going to have to subsidize, not really high on our priority list at the moment. In this webinar, we're going to push a little bit on that and say, really, there really is an imperative for health systems who want to strategically succeed in both the short and long-term future to be proactive in engaging the independent physician market in your market, independent physician community in your market. Because one, we really think this dynamic is a unique strategic bubble that is not likely to be replicated much in the future. We've already talked about how we view the economic factors as driving a consolidation of the independent physician market. This appears to be pretty unique, and we're not really seeing another opportunity. Hopefully, we won't see anything in the future that drives this level of economic instability amongst independent practices. So this is likely to be a one-time, hopefully, is a one-time opportunity. While we don't expect the dynamics around the impact of COVID on independent practices to go away anytime soon, we do expect the windows for health systems to respond to be reasonably limited. And we believe that health systems really should be putting resources into proactively prioritizing and acquiring practices that will drive strategic value, maybe with less of a focus on short-term and more of a long-term focus, and having more of a long-term focus on how do we change ongoing market dynamics 2, 3, 5, 10 years down the road. In our view, failure to do so, one, it invites intervention from outside sources. So one, if we're not proactively making strategic moves with resources that are available for unique reasons right now, we can probably expect our competitors to eventually. Two, private equity money hasn't dried up. We're seeing, private equity activity across the country is extremely variable, but it is clearly growing, and independent practices are not just going to seek employment from competitor health systems, but will seek capital from any number of sources, which really creates an entree for private equity to enter, which we generally view as being detrimental to health system strategic plans. Not always, but in a lot of cases. And then three, it also invites other upmarket competition. So as we're thinking about other players getting into the space of acquiring physician practices that are outside of the private equity vein, there's a lot of avenues of capital right now, even in this environment. So we think the dynamic will be responded to by somebody. We recommend our health system clients are the ones responding to it first. So with that imperative for being proactive, how do we evaluate and prioritize acquisition opportunities? The six most important things to us as we're helping health systems think through this is, one, how relevant is this provider, practice, whatever, to our health system strategy? And we'll talk a little bit more about that in a minute, what that means to us. Two, how do their patients utilize the care continuum in your market? So understanding patient movement from your health systems network of providers to that practice, how that practice utilizes your network of providers within your health system, how loyal those patients are to your organization, et cetera. We'll talk a little bit more about that in a moment as well. And then four, we're not going to touch on as much, but are incredibly important in prioritizing. One is, does this provider address a community need? And if we're not employing this provider, do we run the risk of losing that provider in a market? That's obviously maybe a little less relevant to some of our urban, tertiary hospitals, but certainly relevant in maybe more rural sole community hospital markets, where we're having to make decisions not just on strategic need, but community need. Reputation, both with patients and within the medical community. We certainly want to manage what we're bringing into the employed network and not wanting to bring negative reputation in. Same thing with cultural fit. And then same thing with clinical performance. So while those last four are maybe not the focus of this webinar, they're all incredibly important for how we bring employed providers into our network. But so focusing on the first two, so importance to health system strategy, what that means to us, two critical areas. So one, if we're thinking about does employing this provider help us with our strategy, we're first thinking, one, what does our medical staff development plan say? And medical staff development plans, hopefully within your organization, are not just documenting community need and saying, well, we need 5 more primary care physicians, but medical staff development plans really should be the tying together of what our health system strategy says we want to do, and how we marry that with the providers that we have helping us execute our health system strategy. So the questions we ask from medical staff development planning perspective are, one, does tighter alignment, generally meaning employment, with this practice or provider impact our strategic provider needs? So by changing the relationship, do we address some of the strategic need that we had for a specialty without having to go out and employ a provider and get a practice started up and onboarded? Two, if we lose this practice to a competitor and we expect referral or patient utilization patterns to change, does that create a gap that we'll eventually have to fill with recruitment activity anyways? And does proactively employing this provider save us from having to make a recruitment and build up a new practice? And then three, does this acquisition give us a base for building a specialty through recruitment that we've historically been unable to grow? So what that looks like in a lot of markets is we may have a lot of our service lines and specialties employed, but feels like in every market that's heavily employed, there's still 1 or 2 specialties hanging out where independent groups have gotten traction. They do a good job of splitting their volume between 2 or more health system competitors. And we really don't want to get into the business even if that group isn't completely serving our needs, say it's an orthopedic group, and they're not completely serving our call coverage needs, we still don't want to build up our own employed orthopedic group and risk having them turn on us and shift their volumes. So the question we ask here is, if we do have, say, orthopedic need within our system, but we've historically been at the mercy of an independent group, does employing an existing independent group who may be looking for acquisition at this point, does that give us a base to build on? And that adds additional strategic value beyond just the acquisition and the transaction. The second part we recommend looking at is service line strategy. And so one, as we're evaluating practices, how critical is that practice to accomplishing our service line goals? And increasingly, we're seeing health systems try not to have core service lines very reliant on independent specialties, but that certainly exists in a lot of the markets we work in. So do we have to have this practice, and what does it do to our service line strategy if we don't? Two, does that practice control a critical amount of directable patient volume? So that's maybe a little less important, maybe at the surgery level, but certainly important at the medical specialty and primary care level. And what do we lose within that service line if they're controlling patient volume and we don't react? And then three, for specialty practices, the thing we always encourage organizations to think about is, how good of a control over the referral network do we have? And that largely relates back to primary care strategy, but there's obviously a number of specialties that control patient referral volume. But do we have, maybe in some cases with specialty practices who approach us, we don't need to make an acquisition, and we're largely agnostic whether they join a competitor or leave the market, because we control so much of the referral volume that worst case we can build up our own group, and we don't have to make an acquisition and spend time and capital doing that. So those are the two things that we think are most critical to focus on from a strategic perspective. From a patient utilization perspective, we recommend organizations look at two things as they're evaluating a group for potential acquisition. One is, what do their patient utilization patterns look like? And so this is an example. It's blinded data from a client that we worked with last year, helping them evaluate an independent family medicine practice. And as we looked at how their patients moved across our network, so you can see across the top we've got specialties that our client employed, and we were looking at how well do patients travel from that primary care practice to our employed specialties. We saw this was an extremely loyal group, and the example we have here is with surgery. 90% plus of their patients that end up receiving care from a general surgeon were going to our employed specialists. So one, you could look at that and say, well, we don't really want to employ that group. We're getting all the downstream benefit without having to employ them. But in a situation like we're in now, where that practice is probably feeling a lot of economic instability, that's a practice that would be critical for us to keep, and that it's critical that we don't lose that practice to a competitor and have these referral patterns change. So this is what we call patient shared care, and we think it's critical to understand for any practice that you're considering evaluating. How do those patients move across the care continuum, and how relevant is that practice to us? The second thing we recommend looking at, maybe more from a surgical group perspective, is looking at how is that practice utilizing our health system versus their own resources versus other competitor resources, as we talk about where they bring their cases. And so you can see in this example of an independent orthopedic group, they were bringing a little less than half of their cases to the health system, but weren't bringing them to competitors. So that was generally viewed as pretty positive, while doing 56% of their volume in their group, in their office, or in their ambulatory surgery center. So understanding that dynamic is critical, because that gives us a view of, one, if we're not making this move, where does that 44% go? Two, if we're buying an ASC as part of this, that's maybe the incremental opportunity that we're currently not participating in. and either can we shift those volumes to the health system, or do we want to jointly run an ASC? And then the third thing we recommend is looking at, even within a group, who are the dominant providers? And that maybe goes back a little more to if we don't acquire a whole group, but we're looking at maybe splintering a group, or a group that is splintering on its own. Who do we really prioritize, and who are really the big players? And you can see within this group, there was really one dominant player, and a lot of other players who, certainly had volume, but maybe were less incrementally important. And this is what we call provider service location analysis. So these two things, patient share of care, provider service location, critical to understand for any group that you're thinking about employing, as we evaluate those two strategic questions of, is this practice relevant to our medical staff development plan, and is this practice relevant to our service line strategy? So with those things talked about, at this point, Neal Barker is going to come in and talk about, once we've identified and prioritized a practice, how do we execute a transaction successfully? And Neal?
Thank you, Travis. So, as Travis said, after we've gone through that process and analysis, and whether we've proactively approached a group or a group has approached us, what's the executing the deal? What does that look like? And so what we've highlighted on this slide is basically the sequence of events or tasks, milestones that we think are part of that process. And key to that process is knowing what you're getting into. A lot of that will come out of, and I've highlighted here 3 major milestones in the sequence of events that we think are key. So top of the list would be the operational assessment, or you might refer to it as the preliminary due diligence. So we're gonna sit down with the group and the physicians early on, and we've decided that yes, on the surface, the analysis, strategically, community need, this group makes sense for us to talk to, and then we may want to employ. So we're gonna sit down. We're going to sign a non-disclosure agreement, a confidentiality agreement, and we're going to ask that they share some data and information with us. And then we're going to do an operational assessment, our preliminary due diligence, and understand, what the practice looks like from a numbers perspective. And we'll talk about the details of what we're looking for in a minute. And a lot of these events, while there is a sequence that we put on here, there is some overlap that probably can happen. You can be, while you're doing the operational assessment, the practice valuation can be going on. People can be, trying to pull together financial pro formas, and so on. So as you go in practice valuation, pro forma, the compensation model, and overall package, you're going to develop a term sheet that's going to have all the major deal points for the physician to consider. There'll be a little bit of negotiation. At some point, assuming things look good from both sides, there's going to be an agreement, so you might sign a letter of intent. At that point, attorneys are drafting contracts. There might be a little negotiation after that on certain terms and points on the draft contract. But at some point, you're gonna come to an agreement, and after the rest of the kind of nitty-gritty due diligence is completed, there'll be a signing of the agreements, a closing, and then we're going to be transitioning the practice from independent to an employed practice. So on this slide, what we've highlighted are what we think are just some key areas early on to set some expectations with the physicians, the providers, and the practice overall. Just these are areas that often are concerns at the forefront, and we just think it's best to be proactive and set those expectations early on. One being compensation, one that you probably internally have some standards that you're going to adhere to as far as perhaps the structure of your compensation, what that looks like from practice to practice and specialty to specialty. So you want to share those factors, those parameters, those standards early on. We all have fair market value and commercial reasonableness standards that we have to adhere to. That's for an independent physician in practice. Sometimes that's, foreign language. And so we want to be upfront about those issues and those parameters. And the sub bullet that we've added here is, we're seeing a lot with COVID-19, we're seeing physician views and desires related to compensation really change. And so just have that in mind as you're kind of going into this. Some of your internal physicians, your already employed physicians, their views and desires related to compensation are probably changing, but the same would be true for independent physicians. So, having, revenue minus expense models or pure eat what you kill production models may not be as attractive as they once were before we had to deal with, and practices had to deal with, COVID-19. So we just put that on there as a caveat to keep in mind. Be upfront about your formal approval process and the timeline for completion. This too, with physicians, independent physicians, is going to be foreign. Let them understand the pace that the hospital moves at, the meetings, physician transaction meetings that have to occur. Sometimes those are on a schedule and they don't happen, but maybe every couple months or every month, and so we have to work around that schedule of those meetings. So just be upfront about that timeline and those milestones that we need to hit in order to have an approved deal. Be upfront about the valuation approach. There's a standard of what we can pay for. That as a community hospital or a for-profit health system, it really doesn't matter. If we're participating with Medicare or Medicaid, that there's stark requirements, and there's just generally a valuation standard that we have to adhere to. So be upfront about those. Also, if you have standards with your hospital, your health system, that we typically just don't buy practices, we don't acquire practices, we don't purchase stock, we just do asset deals. Be upfront about those standards and make sure they understand that. We also, we don't buy trained and assembled workforce or medical records, any other components of value. Just be upfront about those standards that you're going to adhere to. And then make sure you're addressing for them concerns that they're going to have about their staff and the impact that this deal and this transition is going to have on their staff. That's always a concern for most of the physicians and the practices that we deal with. So the practice assessment process and due diligence. So we've got the assessment, which again I referred to as kind of the preliminary due diligence. That's a little bit more high level assessment. You can see here we've listed the kind of things that we're going to look at. Top of the list, we've got tax returns and financial statements. That could be an either or situation. Some practices have both. I mean, all practices are going to have tax returns, but some also have annual audited financial statements that they produce and look at. Either one would be sufficient. If we can get both, it's great to have both that we can compare to. And then we've highlighted on here the last 3 years. That's kind of a valuation standard that you're looking at multiple years, at least 3 years of data for doing the valuation, assessing a practice for valuation. But here we think it's, given COVID-19, it's probably a little bit, even more important that we're looking at multiple years, that we're not just looking at 1 year, could be this year. So we want to look at multiple years of financial information as well as productivity information, and understand, what the practice is capable of in terms of overhead expenses, revenue production, work RVU, and patient production. As far as the due diligence information, so here then, again, that we start doing the due diligence after we've gone through the assessment process and said, yes, this is a situation that looks favorable. This is a group that makes sense to potentially employ. And so we're going to kind of that next stage. So we're getting into, the minute detail of looking at payer contracts, insurance details, software licenses, all those sorts of things, vendor agreements, and understanding, what those details are. So looking at medical records and service agreements and so on. So the practice valuation. So here the practice assessment is going to reveal, if another approach, if an income approach, for example, is warranted. Most of the time in physician practices, there isn't the free cash flow that's necessary to consider an income approach. That's not always the case, but most of the time it is. Most of the free cash flow that might be in a practice goes to the physicians in the form of compensation. But in some cases, another approach might be warranted. Regardless, some hospitals and health systems say it doesn't matter, we only do assets, but that might be a little bit short-sighted in most situations and markets. But be upfront about those standards that you have, and make sure that the physicians understand that. In either case, we think it's important to have a third party, a qualified third party appraiser, either doing the full business valuation that might be warranted in a practice, or just doing the pure asset valuation. And I think in either case, having a third party who's arm's length to come in and say what the value is has a lot of value. Both from a getting it right perspective, but also from a compliance perspective. So if you're doing just a pure asset valuation, we've just got some helpful tips on here. Using the depreciable asset list of the practice, if that's available, is a helpful guide. You'll want to physically inventory all the assets, make sure that regardless, even if we have that depreciable asset, that we're going through and physically inventorying all the assets owned by the practice. A lot of times those depreciable asset lists are not kept up to date. There's a lot of old equipment that might be left on there. There might be new equipment that's not been added, so it works both ways, but make sure we do a physical inventory of all the assets. We're assigning a fair market value to each asset, which again is where it really becomes important and can be helpful to have a third party who does this to put a value on that used office and medical equipment. Make sure that we're excluding leased items. That any items that are leased, that we may just assume the lease, make sure we're not paying for those twice. Same with anything that we say, we'll provide, that a piece of equipment, or we'll buy new. Terminate, if we're going to terminate the lease on an item, let's make sure that it's excluded. And then it's important, if we're not going to utilize an item, if there's something that in the practice that we're not going to utilize. A lot of times we see computer equipment, hospital IT will come in and say, we're not going to support the computers, the monitors, all the ancillary computer equipment that the practice has. We have our own that we're going to support. So if you're not going to use those items, let's make sure that we're not paying for them. So exclude those items that we're not going to utilize in the practice or in any other way throughout the network. And then finally, let the physician and the practice review the list for accuracy and make sure that they're given the opportunity to strike anything off that's personal or something that they want to keep as a final step. So the practice assessment process. So what is it going to tell us? What questions is it going to answer for us? So what it's going to do first is it's going to tell us each provider's historical level of production. It's going to tell us, given that level of production, how does that correlate to the level of compensation? What are the coding patterns? Do we have any concerns that we need to dig into coding? A lot of times at this level, it is very high level, and we can do some comparisons of coding versus CMS data or MGMA data that we have for a given specialty. But does that high level look at coding, does that suggest that we need to do a deeper dive into the coding and look at the documentation and the coding patterns of any of the providers? What are the practice's challenges from a payer mix and a revenue cycle perspective? Any issues that we're going to have to deal with when we take the practice on? What types of procedures are they performing in the office? Do we think it's appropriate? Is there something that we're going to have to prepare for as we bring those procedures into the network? Are there any ancillary services that are being provided or could be provided if they had the resources? What does the practice's overhead look like? Any challenges or opportunities there? Obviously, staffing, salaries, and benefits of the staff is important to understand. Staffing ratios will be looked at. How does that all fit into our current standard as far as perhaps salary and benefit structures? Is there going to be any concerns there? Malpractice, what are any concerns and costs that we have related to malpractice? And then technology challenges, this kind of relates to, buying the equipment. Do we have anything that is too old in the existing practice and we're going to have to buy new? What do we do about, connectivity? Those sorts of questions will have to be answered through this process. And then finally, how do the practices providers fit into our existing compensation structure? Some of the, what do we compare to for the practice assessment? You can see listed here, just, at a high level, just some of the data. Obviously you have, as a network, you're going to have lots of internal data that you can use and compare the practice to see how they stack up to your existing specialties, physicians and practices. But we also look, and this is important from a fair market value perspective as well, looking at survey data. So we've just got listed here, AMGA, IHS, MGMA, and Sullivan Cotter are some of the major survey sources that we look at through the assessment process. So on this slide 22, basically just some examples of the output of that assessment process. So some of the comparisons that we're doing, some of the data that we've looked at and what it's telling us. So in the upper left corner, we've got basically some orthopedic practice work RVU production compared to survey data with corresponding percentiles. So what that might look like for you doing an assessment. To the right of it, we've got payer mix information. So what does the practice's payer mix look like? And how does it compare to, in this case, the MGMA mean? Looks pretty close. So, how does that correlate to the hospital's, historical payer mix and the network's historical payer mix? Are there any concerns, any challenges that we're going to be bringing on any opportunities for revenue pickup, and looking at the payer mix. To the bottom left, we've got the coding curves and what that might look like, where we're comparing their coding to data that we have from CMS. And so what is it telling us? On the far left, it's telling us that this particular practice really likes the level 3 code. We see that a lot because it's it's safe. It's safe and there's less concerns, and so, but there might be opportunities for some education there, that, hey, you could be coding more level 4s, level 5s, which, provides a revenue pickup for the practice. And then on the far right, we're looking at some of the revenue cycle metrics, and does that tell us anything and reveal any concerns that we have with taking the practice on? So slide 23, just looking at, when we're thinking about compensation, just make sure that we're understanding, their historical and demonstrated compensation per work RVU if you're on a work RVU type model, and how does that current range, fit within our ranges for our other employed providers in the same specialty. And then we've got caution here too that, we've heard recently, some groups using the published compensation per work RVU rates from, say, MGMA. We just caution you to not do that. As we've shown here, we like to, look at a lag in compensation. So typically compensation will lag behind the level of production in most markets. And so if you look here, we've said that, if you think about median compensation at $302,827, an appropriate lag might be that individual is actually producing at, say, the 60th percentile. And so a rate of 56.68 probably makes more sense and is financially sustainable more than a rate of 63.37, which would be perfect comp per work RVU alignment. We just think that perfect alignment is expensive. So just suggest that and kind of taking that view and that approach when you're thinking about the compensation. But above all, caution you at using the published comp per work RVU rates. Those can be quite expensive. Another output of the assessment, just scatter diagram that looks at the alignment of compensation with production. So again, looking for the relative alignment is one way that we view this. Usually with larger practices and across networks, but just wanted to provide this view of the compensation and production alignment. With that ideal range being, that you see there in the red. And each quadrant means something a little different as far as, are they overpaid, underpaid, what concerns do we have? So just one view that you can use when you're looking at comp and production. So the practice assessment, what we've got here is just some examples of what we might take away from the process of the practice assessment. So for example, we've said that, productivity, we've done the practice assessment and it's telling us that 60% of the providers are below the median for their specialty. So this is indicating that there's some capacity. So some of the things that we might be planning for is we need to understand the referral patterns to the group. Are there opportunities as we're looking at the claims data that Travis talked about? We're looking at some of those referral patterns based on those referral patterns, do we have opportunities available to us because of the primary care base that we have in our network? Do we need to think about a robust marketing plan? Maybe the group hasn't been very well marketed, but we have an opportunity to market the group to the marketplace. Do we have too many providers? We've seen some practices that just starting added adding advanced practitioners and maybe diluted, the market that was there and available to them. And then, compensation needs to reflect the level of production. If they're producing at a certain level, then they should earn at a corresponding level. And then you can see some of the other, takeaways that we have here. Just examples of what we might learn from the practice assessment process. So we've got at the bottom here, in summary, that improvements in coding and AR, reduction in unnecessary space and locations are expected to offset increased compensation per work RVU. So you can see just some of the conclusions and some of the things that we learned through going through the assessment process can help us plan for transitioning the practice. So based on going through the process, the discussions, going through our evaluation criteria, we've said, yes, we want to do a deal with this practice. So at that point, we're preparing a term sheet. We're allowing some negotiation, but we know what our parameters and what deal breakers are. We're preparing the necessary agreements, obviously the employment agreement, asset purchase if that's necessary, any lease that, if we're leasing space from the group, we want to prepare those lease agreements. We're going through our physician transaction committee and board approval processes. Fair market value opinions are often required for those approval processes in a lot of cases. So make sure you have those standards and that you have those opinions completed. Plan and have a timeline for credentialing. Allow enough time. Don't get too far out ahead of yourself. Don't make too many promises that you can't keep. We want to allow enough time, we think at least 90 days for credentialing, because at worst, you don't want to have to delay a start, one, but worse than that, you don't want to, get in a situation, and we've seen organizations and health systems do this, where physicians not credentialed, and so you're providing services for free. So just don't end up in that situation. Due diligence. So this is, again, a little bit more of a deeper dive. And so we've got here, some of the things that we take away from the actual due diligence process. The hospital IT team has completed their walkthrough. We're not going to be purchasing the IT equipment, is something we learned through this. New computers and new phone system are required. We're not going to renew the copier lease. We have to give 30 days notice. Facilities team from the hospital's done a walkthrough on the space. We're going to lease the space from the physician-owned holding company. So we need an appraisal. We need fair market value opinions. We're not going to renew the hazardous waste removal service that the group has, because we can handle it on our own. Those sorts of things, and there's lots of other areas that we would cover and address in a similar fashion. And we usually use a comprehensive due diligence checklist as we're going through this, this step of the process.
All right, thank you, Neal. And so we're going to wrap up today by talking just a few thoughts on management priorities in a post-growth environment. So we've talked about our observations that independent practices are probably going to be seeking employment in a fashion that we haven't seen in probably the past decade in most markets. We've talked about how we want to prioritize those practices, and we've talked about how to create a successful transaction with those practices. So now we want to talk about a little bit about management priorities for 2021, kind of post that growth. So once organizations have kind of acted on the current environment, which again we expect the second half of 2020 really to be full of independent physician transactions. What do we do? What's the implications of that for our employed network, and what do we need to be focused on? And so for anyone who's interacted with our company before, you've probably seen our physician network growth phases, which talks about how employed networks grow and kind of the path on which they evolve. And as many networks have told us, operational chaos is the painful part. It's the part where we've done all of our growing and we need to figure out how we actually manage the physicians that and the providers that we've employed. And that's usually fraught with loss, discussions about losses, not having enough resources and fighting fires on a day-to-day basis, and having a sense that we can't really work on anything strategic or move forward because we're just dealing with the day-to-day. So we know that that's a place that that we know is inevitable with growth, but it's something we want to get out of as quickly as possible. And when we look at the curves, the one thing we're concerned about is, this continuum is not linear. It's certainly something you can move backwards in. And what we're concerned about for health systems as they think about the implications of bringing more independent practices into their employee network is for networks that have made it through, have made it past rapid growth and grown their network, have made it through operational chaos and kind of dealt with the pain of building competencies in physician network management, and gotten losses down or tolerable and moved on to being able to leverage their network for success. Is there the risk of re-entering another rapid growth phase as our network increases by 10 or 20% in size over a handful of months, which we think is realistic in some markets? And so what are the implications of doing that, and what should we be focused on? So our general advice for employed physician networks owned by health systems, significant growth in an employed network requires us to reevaluate a number of things related to managerial and cultural dynamics within the organization. So one, anytime we bring new practices in, it's a great time to come in, take a step back and say, how are we doing overall from a performance perspective, financially and operationally? How do these new practices fit in? And maybe 3 to 6 months post acquisition, how is everything fitting in financially and operationally? And do we have any actions that we need to take? Two, when we start bringing in when we rapidly grow and start bringing in a number of providers, that's a great opportunity to either create, or if you have one, reevaluate your shared vision of the network. And vision is not, we're going to be the best employed network in the country and we're going to be here to serve our community. Shared strategic vision is a document that defines the cultural expectations of administration and providers and working with one another, why this network is critical to the health system success, what obligations the providers have in being a part of it, what obligations administration has in helping execute that network. So it's a great time to reevaluate that shared vision and expose the providers who have recently joined to expose them to that shared vision document, so they can understand cultural expectations in a way that they might not otherwise. Three, when going through rapid growth, it's a great time to reevaluate your management infrastructure. I think a lot of networks, if you're not already, are kind of in the, we really need to evaluate our management infrastructure anyways in a post-COVID environment, because a lot has changed over the past 2 months. But especially as your network grows and you either talk about bringing in new service lines or specialties, you've moved into different geographic areas through acquisition, or your network has just grown to the point where new bodies have to be added in order to make the management execution of the network work. It's a great time to reevaluate management infrastructure. And then similarly, it's a great time to reevaluate physician-led governance, because as we start again talking about rapidly growing our network and increasing its size maybe by 10 to 20%, those are physicians that we need to involve in governance. That's a great time to think about what the composition of our governance structures are and how they're utilized, and what role new providers who have been brought into the network from an acquisition standpoint and not just a recruitment standpoint, what role they play and how we get them even more tightly integrated into the organization. So those are the things that for organizations that do act upon the focus of this webinar, which is aligning with independents that maybe historically haven't been wanted to be employed. These are the things that we think organizations really should be focusing on kind of after that growth happens, to make sure that the employee network, the operations aren't disrupted and that financial sustainability remains a core goal. So with that, that's the end of our content for today. We'll remind everyone that we have upcoming webinars every Thursday at 2 o'clock Eastern. Our next one is employed leadership considerations for the second half of 2020. So really diving into what health systems and employed network leadership need to be focused on, kind of in a post-COVID, at least in a post-surge and post-reopening environment. What do we see coming up, and what are we hearing organizations are working on? We also have supplementary resources across our website. If you go to our website, hsgadvisors.com, we have a COVID-19 updates tab, which kind of aggregates all of our content that has any relevance at all to what's going on in a post-COVID environment. And with that, we'll take questions. Neal, if you don't mind, I'll go ahead and look and see what questions we have, and then maybe throw them to you and we can discuss them. So we have one question. It says, is there a projection on how long enhanced telehealth rates will continue before returning to the lower pre-COVID rates? Neal, I don't know that I've seen any guidance on that. Have you seen any recent guidance on that?
I have not, but good question, and I think we can take a look, and it's something that Dr. McWilliams in our group probably has his finger on.
Yeah, I've in the research I've done on, I've been looking in, I have looked into that in the past month. I think we're hoping legislatively that we don't see a return to lower pre-COVID rates. Thinking telehealth and virtual health adoption, our position is we hopefully aren't doing anything to disrupt what's been done over the last 8 weeks. I've been fond of saying everybody's executed kind of a 10-year virtual health strategy in 2 months. I would personally hate to see the reimbursement lessened, just because I think that will slow down the adoption or the continued use of virtual health. But directly answering the question, we don't have a perspective on that. All we know is that they are still scheduled to, the rates are still scheduled to expire when the public health emergency is lifted. When that is, we're kind of up to, we don't have any additional insight on that. So with that, we have no other questions. We thank everybody for their participation. Neal and I's contact info is on the screen. And if you have any questions that you didn't want to submit through the webinar, and as a reminder, this content will be available on our website and will also be emailed to anybody who attended today. So with that, thank you for your participation. Neal, thank you for your participation. And we'll see everybody next week.
Thank you.